It gives me a great honor today. I'm Joel Schnur. I'm the chief of the Division of Endocrinology in the Department of Medicine at the College of Medicine. And it's really a privilege to introduce my faculty colleague, Dr. Matthew Gilbert. Matt's an associate professor of medicine and the program director for our fellowship in endocrinology. He's also the inpatient diabetes director, fixing things when patients get hospitalized and making sure that their diabetes stays on track. He obtained his bachelor's degree from Susquehanna University in Pennsylvania, and he graduated from the New England College of Osteopathic Medicine in 2003. And then he completed his internship residency and chief residency at Bassett Memorial Hospital in Cooperstown. After serving as chief resident, he came to UVM as a fellow. We were lucky to get him. And along the way, he earned a master's degree in public health at Boston University's School of Public Health. The good stuff starts after he arrived at UVM. He became the program director for our fellowship, recruiting great fellows over the years. He's been a leader in improving inpatient diabetes care, and he's also been a stalwart in our sim lab. So we have an area where we can take trainees in simulated patients, and that's how they learn how to do stuff not in a real clinic setting, getting ready to deal with real live patients, and it's fantastic. This gives them a real-life experience before they have to do real-life experience. So Matt's presented papers at local, regional, national, and international levels. He just got back from Berlin, where he presented a paper at the European Association for the Study of Diabetes, which is a big deal. He's also authored many scientific papers and chapters in textbooks. His research interests include incretin hormones, which you'll hear about later, so I'm not going to go into details on that. The role of diabetes treatment in bone turnover and why some diabetics are more prone to fracture, and inpatient diabetes management. Shown in a short period of time, he's really made a national and international name for himself. However, despite all that stuff that you read in a resume or a curriculum vitae, as you'll hear, he has a reputation of being an excellent mentor and teacher. So we're very lucky to have him address the community medical school tonight, and he's going to present a talk, as you can see, on pumps, sensors, and meds. Oh my, treatments for type 1 and type 2 diabetes. Matt Gilbert.
Well, thank you very much, Dr. Schnur, and thanks everyone for coming out tonight. It's exciting to see some of my patients in the audience. I hope they're not making sure to check up on me or here to heckle me, but feel free to do either. My title is a throwback to, of course, The Wizard of Oz, and the question that most people will have to answer is, yes, I am still afraid of the flying monkeys. So I'm going to start tonight on a somber note. This is Angel. Angel was a patient of mine who we lost almost about a month ago. Her family's here with me tonight. And I put this in memory of her today and of all the patients that we as providers have lost to diabetes over the years, because regardless of what we talk about tonight, we're going to look at scientific data, we're going to look at new technologies and new devices. The reality is that my job as a physician and your job as a public and as a patient is to reduce the rates of complications and to improve the lives, the quality of life for our patients with diabetes. And I just wanted to let her family know that I miss her. And I didn't get a chance to say goodbye to her, but this is a way to honor her tonight. So for tonight's talk, you're always supposed to tell people what you're going to tell them. So this is what I'm going to tell you tonight. We're going to talk about the prevalence. So how common is diabetes in the United States? Not only in the United States, but around the world, because the numbers are quite staggering, which we'll see in a few moments. We're then going to discuss the cost of diabetes, and not only the physical cost, but also the human cost of diabetes in 2018. And then we're going to transition to talk about a lot of new treatments, whether these are medical treatments, such as injectable medications or oral medications, but we're also going to talk about a lot of the new technologies that are available for patients that really have become available over the last few years that are beginning to revolutionize the way we take care of patients with diabetes. And we're going to see talk extensively about those towards the end of the talk. And at the very end, I'm just going to give you, I can't stand up here in front of a bunch of people and not tell you the best way to take care of diabetes. So we're going to go through some basic things that either you or your family members can do to help take care of your diabetes. Just from a show of hands, how many folks in this room today know someone who has either type 1 or type 2 diabetes? So it shows certainly that the impact is quite significant. So I hope that I'm able to share with you today some things that you can bring back to those folks or use yourself to improve the care of your diabetes. So what's the current state of diabetes in the United States? Well, this is data from 2017. I recently saw updated data from 2018 that puts the percentage of Americans, of adult American population with diabetes, closer to 14% rather than 12%. But you're talking about 30.2 million Americans in the United States have diabetes. And what's staggering is that an additional 7.2 million patients in this country have diabetes but don't know they have diabetes. One of the major issues with this disease is that, particularly in type 2 diabetes, you may not be particularly symptomatic when your blood sugars are mildly elevated, and therefore patients go long periods of time if they're not seeing their physician or their provider regularly. They don't get screened, and we don't identify these patients that have the disease, and therefore we can't start early treatment. 34% of adults in the United States have prediabetes. And we know that if you have prediabetes, there's a significantly increased risk of developing diabetes down the road. Although there are some roadmaps as to how we can prevent that, and we certainly can talk about that in detail in the question and answer session. But this is a wave behind the wave, so to speak. 25% of adults in the United States over the age of 65 have diabetes. And if you're in this room and you're over the age of 65, there's a 48% chance that you have prediabetes. So just to give you a sense of the numbers, I think when we talk about millions of people, sometimes that's hard to fathom, but this is a large chunk of our country that is suffering from this condition or may suffer from this condition down the road. So I picked 1994. That was the year that I graduated from high school. You can see here that I'm not good with colors. I don't know if this is maize or brown. We'll call it brown for the sake of argument. If you look at the brown colors, of which Vermont is included, you can see that those states have a prevalence of less than 4.5% of their state's population have diabetes. You can see the winner, at least in 1994, was South Carolina, which had between 6.0 and 7.4% of their population with diabetes. Again, this includes both type 1 and type 2. As you know, the vast majority of folks will have type 2 diabetes, with a much smaller percentage suffering from type 1 diabetes. But you can see here, this is 1994. In contrast, this is 2015. And what you see here is that I wanted to say every state below the Mason-Dixon line, but that extends all the way out to California, Nevada, and Michigan as well. You can see that these states have greater than 9% of their population that have type 2 that have diabetes, and this number, unfortunately, is only estimated to continue to grow. There was a CDC report that was released in 2010. That said, if the prevalence of diabetes continues to rise at the prevalence that we're seeing over the last, say, 2 or 3 decades, and we do a better job at keeping patients alive with diabetes, which I'm going to show you some data, we are doing a better job by reducing complications and allowing people to live longer with this disease. If those two things happen, which they are happening, by the year 2050, 33% of the U.S. population will have diabetes. That's 1 out of every 3 people sitting in this room tonight. So staggering numbers when you talk about a true epidemic in our country. So the challenge, we have 30.2 million patients with diabetes. We talked about the additional 7.2 million patients with diabetes that currently are undiagnosed with diabetes. But remember, when you talk about icebergs, it's not necessarily the iceberg that's above the water that you have to worry about. It's the iceberg below the water. And there's another 84.1 million patients in the United States who have prediabetes. So what about worldwide prevalence? So you can see here, it's color-coded. It's probably hard for some of you to see. The bluer colors represent Eastern Europe, Central Europe, Southwestern Europe, Northwestern Europe. High-income English-speaking countries are in the lightest blue. And you can see here that our numbers have maintained fairly steady since 1980. But what you see here is that other parts of the world are exploding with regards to their prevalence of diabetes. These countries that you see up in the top here, this is the Middle East, Southeast Africa, or Southern Africa, Central Africa, West Africa, and East Africa, which I believe makes up most of Africa. You've seen that from 1980, they had approximately 100 million patients with diabetes, and by the year 2014, they were over 400 million patients with diabetes. So dramatic explosion of diabetes worldwide, with particular emphasis in the Middle East and Africa, as well as Southeast Asia. So what about the economic costs of diabetes? So every year, Diabetes Care, which is the publication of the American Diabetes Association, puts out a paper, typically in the springtime, looking at economic data with the results of, or from the care of patients with diabetes. And the reason why we do this is not to make us upset or sad. The reason why this data is presented is that the ADA wants us to use this data to help drive public policy, and to drive public policy not only in our state houses and perhaps at the federal level, but also in our boardrooms here at the University of Vermont Medical Center. And these are the kind of data that I use when I'm at meetings to try to persuade additional resources, et cetera, to treat patients with diabetes, not only in the outpatient, but also in the inpatient setting. So I wish these numbers were better than the first set of numbers I showed you, but they're not. In 2017, we spent $327 billion on patients with diabetes. And what is staggering is that $237 billion of that number is spent on direct care of patients with diabetes with regards to care of their complications, all right? And there's another $90 billion that in reduced productivity, patients who have to miss work or who are out of work for an extended period of time because they have a foot ulcer or had an amputation or had a bleed in their eye which caused them to lose vision. So there's a tremendous cost to not only taking care of those folks in the hospital, but there's a tremendous cost of taking care of folks who aren't able to go to work and therefore lose productivity that way. Another staggering number, the direct costs have increased by 26% since 2012. So our care is getting more and more expensive every year. There are more than 300 million workdays are lost to the economy due to diabetes, and the diabetes directly resulted in almost 277,000 premature deaths in 2017. So again, I threw a lot of numbers at you today, but I want you to remember that first slide. Every single one of these numbers has somebody behind it, right? Has people that we know and that we love and that are in our community. And we really need to work together to start turning the tide of these particular numbers. If we look at some additional economic data, how about costs of medications? This has been a big issue over the last several years for sure. We spend $31 billion a year on medications directly used to treat patients with diabetes. Half of that, or almost half of that, is for insulin alone. And you've probably heard Senator Bernie Sanders. You've seen advocacy organizations such as the American Diabetes Association. You've seen prominent diabetes physicians, world-famous diabetes physicians who also have type 1 diabetes themselves, bang this drum for many, many years now regarding the cost of insulin. We've seen the increase in the cost of insulin rise by 45% over the last 5 years. So since I've been practicing in 2007, I have spent more time over the last several years taking patients off the newer designed insulins that more closely mimic physiologic insulin secretion and have been shown to do a better and safer job at controlling their diabetes, and had to place them on medications that were available in 1981. And the reason is that patients can't afford their insulin medications. So that's a major public policy issue, which we won't solve today, but something that we need to keep in the back of our minds at all times. 1 in every 4 healthcare dollars is spent on a patient who carries the diagnosis of diabetes, and 1 out of every 7 healthcare dollars spent in the United States is spent directly on the care of someone with diabetes or their complications. So I borrowed this slide from a member of the American Diabetes Association. I think it really puts in perspective, we just spent a lot of time talking about money. While that's certainly important to certain people, and it should be important to us and policymakers, I'm more interested in the human cost of diabetes, right? That's what I see every day. That's what I try to, in my clinic every day, to try to prevent complications and to improve the quality of life of my patients with diabetes. So I just wanted to put this puts the perspective of diabetes, and it contrasts it to another severe medical issue we have in this country and in our state, the opioid crisis. So in the United States, every 2 minutes, a person with diabetes has a stroke. There's one case of ischemic heart disease or coronary artery disease diagnosed every 80 seconds in the United States. There's one case of kidney failure every 10 minutes in the United States. And every 5 minutes, there's a patient with diabetes who loses their lower limb. If we contrast that, now this is 2016 data. Unfortunately, the data of the opioid epidemic has not improved since 2016, and this number is likely, unfortunately, higher. But every 52 minutes, a person dies from an opioid overdose in the United States in 2016, and we lose more than 46 people to that epidemic per day. And again, this number is underrepresented as the problem has only increased since 2016. If we contrast that to diabetes, there's a death from diabetes every 2 minutes. So that means we lose 768 people a day, or approximately 280,000 Americans per year. So that's the gloomy part. Now we're gonna build ourselves back up here and talk about what we can do about all this. So how do we prevent complications of diabetes? Because that's really what we're talking about. How can I prevent someone from developing those complications, whether it be eye disease, kidney disease, peripheral vascular disease, heart attack, strokes? How do I prevent those from happening? And what we do know from really, really large trials that were conducted in the 1990s. Now, take a step back from that and think about that. It wasn't until the mid-1990s, right, when I was in high school and early college, that we actually knew what target we should shoot for with regards to where someone's blood sugar should be. That always blows my mind. We've known about diabetes since thousands of years BC, and we've had medications to treat diabetes since the late 1920s. But it really wasn't until the early 1990s that we had any idea where the target should be to help reduce some of those complications. And what you see here on the chart, this is from a UK PDS. This is one of the most famous diabetes trials ever conducted. It's still referenced almost daily, probably in any academic endocrinologist office who is teaching fellows. And what this study did is it looked at intensive control of blood sugars versus conventional control of blood sugars. So if you look down in the bottom here, which I'll highlight here, you can see that the A1C, or the average blood sugar control, was 7.9% in patients in the conventional treatment group. And the intense treatment group, they got their A1Cs all the way down to 7%. And what you see there, by that 0.9 on average, 0.9% reduction in A1C, you saw a 12% reduction in any diabetes-related endpoint. As far as microvascular complications, so these are complications such as retinopathy, nephropathy, and neuropathy, you saw a 25% reduction. In patients who had to undergo laser treatments for retinopathy, you saw a 29% reduction. Presence of small amounts of protein in the urine called microalbumin, which is the initial signs of kidney damage from diabetes, that was decreased by 34%. And although it wasn't statistically significant, you saw a significant trend in the reductions of heart attacks or myocardial infarctions in this trial by 16%. This was so this was really the first time, and again, it blows my mind that it was the 1990s, but it was the first time that we showed that a reduction in A1C to a specific target, okay? And that A1C just represents an average blood sugar of around 150, okay? So an A1C of 7 is an average blood sugar of 150. That dramatically reduced microvascular complications of diabetes. So this is a trial from the DCCT, another one of the, what I call the Mount Rushmore of diabetes clinical trials. And this was in patients with type 1 diabetes. So the UK PDS was in patients with type 2 diabetes. The DCCT was in patients with type 1 diabetes. And what you can see here on this axis on the bottom, you have A1C going from 6 to 12%. And then on this axis, you have the relative risk. So how much additional risk does a person have of developing one of these complications? The blue line represents retinopathy, the red line was nephropathy, the green line was neuropathy, kind of your three most common microvascular complications of diabetes, which are more common in patients with type 1 than in type 2 diabetes. And what you see here, right, is that a dramatic drop in your risk of developing a complication as you lowered your A1C. And this is why I think it's important. And this is why sometimes I get criticized in clinic because I come in and I give someone a high five who've dropped their A1C from 11 to 10%. We know their goal is 7%, but you can see by dropping their A1C from 11 to 10%, look at the reduction we've made in their risk of retinopathy. So any reduction, any improvement in your blood sugar control over time is going to reduce your risk of developing one of these microvascular complications. And you can see that in this trial as well, all the lines kind of focus around 7. And you can see that the slope of the line really doesn't drop too much further after 7%. So this is where the recommendations come from all the professional organizations, that we really should be shooting as a population of people with diabetes to lower our A1C to 7% or lower, because it dramatically reduces your risk. But I want you to notice, right, we've all known people who have had very good control of their diabetes for many, many years and still develop a complication. And the reality is that you can see here that your relative risk is still not 0. So even with an A1C below 7%, you still have an increased risk of developing a complication. It's just dramatically lower than what you would have if you had a higher A1C. So we talk a lot in my office, and I'm guilty of this all the time. I talk a lot in my office about controlling blood sugars, right? That's what people are there for. I'm there to help them lower their blood sugars. The reality is that diabetes and prevention of diabetes complications is a numbers game. And yes, blood sugar control is one of those major components, but there's other major components of that particular cocktail. And this is data that I wanted to show you from that UK PDS trial. And in the bottom here, you see again, a standard treatment group had an average blood pressure of 154/87, where the treatment group had a blood pressure of 144/82. You're talking about a 10 millimeter per mercury difference in systolic blood pressure and only a 5 millimeter per mercury difference in diastolic blood pressure. But look what that difference does to the risk of developing a microvascular complication. Decreased by 37% of a microvascular endpoint. Progression of known retinopathy by 34%, reduction in stroke by almost 44%, and reduction in heart failure by 56%. So when you're talking about either your diabetes or your family member's diabetes, it's not just about the blood sugars, it's about blood pressure, it's about keeping your cholesterol at a certain level with using cholesterol-lowering medications. And one more major thing is I was born in Troy, New York, which, as many of you may or may not know, is the official home of Uncle Sam. Uncle Sam actually was a real person. He was a meat packer during the Civil War, and he would stamp it U.S. meat, so he was nicknamed Uncle Sam for U.S. So there was actually a person. They dug up his house, and they found his toilet when I was in high school. So that was the exciting thing that happened. Not a lot happens exciting in Troy, New York, but other than digging up toilets he did not apparently dress like this on a regular basis, because no one dresses like this on a regular basis except for Uncle Sam. But what Uncle Sam is trying to tell you is that if you have diabetes, you cannot smoke. Smoking already dramatically increases your risk of heart disease, stroke, and heart attack. You combine that with the increased risk of diabetes, and it puts you at significantly increased risk. So if you know someone who smokes and has diabetes, we got to get them to stop, right? New York, Vermont, and a lot of other states all have great opportunities to reduce smoking through smoking cessation programs. Oftentimes they will cover nicotine replacement, et cetera. So if you have someone in your family or if you smoke yourself, Uncle Sam is very angry with you, and you don't want to make Uncle Sam mad. So how are we doing? That's the big question. So look at 1995. That's when the UK PDS and the DCCT released. And you can see that once we started to have some targets, once we started to have the ability to know at least a target for where we were going to lower patients' blood sugars, you started to see a decline in acute myocardial infarction, which are heart attacks, strokes, amputations, and end-stage renal disease. So some of the slope of those lines are a little bit steeper than others, but what you see that between 1995 and 2010, and this was a study that was published in the New England Journal in 2014, you can see we're starting to begin to make headroads and reduce those risks reduce those complications through the ability to control not only blood sugars, but blood pressure and the advent of aspirin and statins and stopping smoking and exercising and working on your diet. So I don't expect you, this is a Swedish study that was published in 2017, the details of which I don't really need you to remember here, but what I want you to get a sense of is the blue line represents patients with type 2 diabetes, and the red line is match controls. One of the great things about Europe and some of the Scandinavian countries and other countries who have standardized healthcare systems is that they have these huge databases of everyone in their system. So you can do really great quantitative literature or research on populations of people with diabetes. So this was a population in Sweden between 1998 and 2014. And when we first saw this, we were really excited. Look at the dramatic decrease that we've done in hospitalizations for cardiovascular disease, death from heart disease, death from any cardiovascular disease, including strokes. But what do you notice about the two lines? They're still far apart, right? So while, yes, we are making inroads in patients with type 2 diabetes, the general public is also doing much better as well. So there's still a gap between how well someone with diabetes does compared to someone without diabetes. And that's the gap that we need to start to close. I'm excited that these numbers are going down, but we need to begin to start to bring those lines a little bit closer to each other. So what have we done to try to turn the tides here? Well, one of the things that we've done is we've spent a lot of money on developing new medications. So this is a slide that I stole from Dr. Leahy. Actually, I didn't steal it, he gave it to me, so with his permission. But what is shocking about this is look at so insulin was being mass produced in the United States by the late 1920s. By the 1950s and 60s, we started having human insulin on board. But if you look at the mid-1950s until 1995, okay, that's a big chunk of time. All we had to treat patients with diabetes, either type 1 or type 2, was insulin and a sulfonylurea, right? So that's your glipizide, glyburide, and glimepiride. You may think to yourself, holy cow, I might be on one of those medications. You tell me they've been around since the 50s and 60s, and they have been. But it wasn't, you can see that after 1990, you start to see an explosion. So on the left, on this axis here, you start to see the number of classes of medications that are available. And since 1995, we really had an explosion of different medications, mostly to treat type 2 diabetes, although not on here is a dramatic change in the types of insulins that we've designed to work better than the previous older insulins, which we can talk about more so in the question and answer period. So since 2005, this is purposely so small that you can't read it. It's more for visual effect, so your eyes are not going. You don't need to go see your eye doctor right away. Since 2005, there have been 40 drugs approved for the treatment of diabetes in the United States. And since 2005, there's been no significant change in the number of patients in the United States that are able to achieve an A1C less than 7%. So we're not going to solve this problem by designing and making new drugs. They're certainly going to help, but we're not going to drug ourselves out of this problem, right? It's a combination of exercise and diet and medications and advances in technology, et cetera, which we're going to talk about in a few minutes. So we've gone through a lot of data so far. And this slide is meant to let you know, you have to decide, are you a glass half full or a glass half empty kind of person? Certainly, we've heard some information so far that if you were a glass half empty kind of person, I wouldn't blame you right now, right? But I'm a glass half full kind of guy. And the reason is that if everyone in this room, if we were sitting on the boards of hospitals, if we were sitting on the boards of pharmaceutical companies, if we were members of our state legislature, or we were members of our departments of health, or God forbid if we ever became congressmen or senators, right? Or even president of the United States for that matter, right? What do you think would be one of the biggest public health crises that we think we probably should concentrate on in the next 15, 20 years? It's diabetes, right? We talked about if 33% of your population by the year 2050 are going to have a chronic illness that costs a lot of money and is devastating to people's lives at times. So what we've seen is we've seen an explosion. We've seen an explosion in research. We've seen an explosion in the number of medications. And we're going to talk later on is that there's really been a change in the way we study our diabetes medications that has given us a lot of additional information that we never had before. If you look at those drugs from 2005, the trials that got those drugs approved were usually studied on, at the most, 2,000 to 3,000 patients. All right? And those drugs were approved by the FDA on their ability to lower blood sugars. And that's it. All right? So if you could demonstrate that your medication could lower blood sugars and could do so safely without an unacceptable risk of hypoglycemia, your medication was approved for use in diabetes. What you're going to see later on is that now we have these much larger cardiovascular outcome trials that are telling us things about our diabetes medications and our newer diabetes medications that we never had before, information we never had before, and we're now starting to use how to or understand how to act on that information, and it's really changing the way we take care of diabetes. So we're going to transition now to what I call the newish approach to the treatment of type 2 diabetes. So an interesting story, endocrinologists are usually not involved in a lot of drama, which I think is a good thing for endocrinologists. But in 2007, there was quite the endocrine drama. There was a paper that was published in the New England Journal of Medicine by a doctor named Stephen Nissen, who is a famous cardiologist who works at the Cleveland Clinic. And he published what we call a meta-analysis. So what a meta-analysis is a type of publication where you take, instead of just taking one group of patients, you group a lot of studies together to try to build up a large number of patients so that you can look at a particular aspect of the medication. And what he published was a meta-analysis on a medication called rosiglitazone. Its brand name was Avandia. At the time, Avandia had 21% of the market share of diabetes medications in the United States. So it was a very popular medication. It was the first medication after sulfonylureas and after metformin, and it was the first medication that we had that actually addressed some of the pathophysiology of diabetes by improving insulin sensitivity, particularly at the fat cells. So we were really excited about this class of medications, and obviously the 21% of the market share showed how excited physicians were using this medication. Well, this publication came out in the New England Journal in 2007, and it showed in his meta-analysis that there was some concern that this particular TZD medication may increase the risk of heart attacks. So if you take a step back, 8 out of 10 people with type 2 diabetes will die a cardiac death. If you then give them a medication that increases that risk, it certainly doesn't make a lot of sense. And I think there are a lot of things our federal government doesn't necessarily make a lot of sense, but this particular decision they made did. So what the FDA said after that one meta-analysis is that every new diabetes medication on the market that comes out after the year 2007 has to do a trial called a cardiovascular outcomes trial, and it has to prove that it does not increase the risk of cardiovascular disease in patients with diabetes. So initially, the drug companies kind of were really upset about having to do additional trials, because instead of having to do a smaller trial in 2,000 to 3,000 patients to get their drug approved, now they had to do these really large cardiovascular outcome trials. We're talking about 6, 7, 8, even 15,000 patients enrolled in these trials, because what you had to do is you had to have a certain number of cardiovascular events in these trials to prove that your medication was safe. And these trials, instead of being 26 weeks long or 52 weeks long, these were now 2.5, 3.8, 5 years in duration. So we started to gather a lot of new information, which we're going to talk about now. So here are the contemporary cardiovascular outcome trials that have been released since 2013. They are color-coded based on the type or class of medication. What's interesting is the Harmony trial that was just released in Berlin and the Rewind trial, they teased us last week. They released a 3 to 4 sentence release saying that this medication, which is dulaglutide, which is called Trulicity, actually has been shown to not only be safe, but is also beneficial with regards to reduction in cardiovascular disease. So we anxiously awaited a lot of these cardiovascular outcome trials, and what we saw was trial after trial after trial, particularly these ones on the farther end, came back with our medicine is safe, so it didn't cause any increased cardiovascular disease. And for that, we were excited. It wasn't until EMPA-REG outcome trial, which is this one here, which came out published in 2015, and then subsequently the LEADER trial published in 2016, and the SUSTAIN 6 trial in 2016, and then subsequently Harmony, Rewind, and the Canvas program, all published between 2015 and 2018, where now we've seen that not only do these medications not cause increased risk of heart disease, but they actually protect patients against heart disease. And we're going to go through some of that data because it's actually really exciting, and it's going to make your glass half full instead of half empty. So we're going to start with a class of medications called the GLP-1 receptor agonists. Many of you in this room, if you're my patients, may be on these medications, or at least we've tried these medications. So the idea that there's something in the gut, something in our bowel, that signals our pancreas, which is the organ that releases insulin, there's something that a signal would be sent between those two areas is certainly not a new concept. You can see this first was called a factor from the intestines, and that was way back in 1902. The term incretin, which is what we call these hormones, arrived in the 1930s, but it really wasn't until we developed the ability to do radioimmunoassays, which is a specific test in a laboratory to identify certain types of proteins, where we were able to really start to isolate and identify what these particular signals were. And what we found is that there really was a communication between the gut and the pancreas, and they came in the form of two particular hormones. One is called GIP, which you see over here in blue, released from the K cells in the upper part of the small intestine. And the other one was called GLP-1, or glucagon-like protein 1, and that's released from the L cells in here. And what's interesting, and you're going to need to remember this later, so there's no quiz, but you'll need to remember this a little bit later, is that both of these hormones are broken down by the same enzyme called the DPP-4. And that name should sound familiar to some of you, and if not, we'll talk about it in a few minutes. And what's really amazing about this biology is that DPP-4 hangs right around these little crypts in the small intestine. And what happens is that these cells that line the small intestine actually sample, hope everyone ate already, sample parts of the small intestine and release different amount of hormone depending on the content of your food. So depending on the protein content, the fat content, and the sugar content, different amounts of this particular hormone is released. But what's interesting is that this DPP-4, this enzyme, lies in wait. And it sits right there, and it breaks down most of your natural hormones that are produced, both the GLP-1 and the GIP, within minutes of them being released. So it's a really highly regulated system because it's a system that controls the release of insulin and maintains blood glucose. So it's a system that you want to have a lot of checks and balances on, much like our federal government. So we call that, so this is really interesting biology. It's super interesting to me. I hope it's interesting to you guys. The graph you see on the left-hand side, on this axis you have the release of insulin, and on the bottom you have time. And this is a famous study done by Dr. Nowak in diabetology that was in 1986. So we knew about this particular effect in these particular hormones in 1986. But the first commercial medication for these came out in 2006. So you can see that's how far sometimes drug development lags behind the actual biology. But what you see here is that in response to an oral glucose load, so this is swallowing sugar, and therefore passing through your stomach and small intestine, you see a significant and robust release of insulin as a response of swallowing glucose. If we put that same amount of glucose into your vein directly and we bypass the gut, what you can see is a dramatically different curve with regards to insulin reduction or insulin secretion. So they termed this back in '86 the incretin effect. There's something about taking glucose through the gut that it allows for signaling to the pancreas and release of insulin. And what we now know is that that particular signal, that incretin signal, probably accounts for 50 to 70% of the total signal that tells your pancreas, hey, there's food here, I'm absorbing a certain amount of glucose, let's release some insulin to try to keep our glucose under good control and keep that, and drive that glucose into cells. So this is even more interesting. So on the left are the control subjects, which I just showed you, and on the right, he studied several patients with type 2 diabetes. And then what you notice here is that although with the oral glucose load here in blue still, you do see a slightly increased rise in insulin release. It's nowhere near, right, the robust response that you see in patients without type 2 diabetes. So we learned that this is one of the many pathophysiologic aspects of type 2 diabetes, is that patients with type 2 diabetes, their incretin hormones, those signals from the gut, don't work as well as people without diabetes. So in particular, there hasn't been, although recently there's been some renewed interest in GIP, most of the drug development has been on GLP-1. And the reason is that this GLP-1 that is released from the intestine has a number of particular biological effects. You see that it affects the pancreas, it increases insulin secretion by decreasing glucagon secretion, but it also has an effect on the brain. It tells the brain that you're full, so it decreases your appetite. There's a central nervous component here as well. And in the stomach, it decreases your gastric emptying. So as the food moves slower through your gut, you eat less and you feel less hungry. So glucagon-like peptide 1 receptor agonist, that's the class of medications that have been derived from the science I just showed you. And we also have DPP-4 inhibitors. So we found out that that enzyme broke down GLP-1 and GIP very quickly. So what we did is we designed medications to stop that breakdown and allow for more of the natural GIP and the GLP-1 to circulate in the bloodstream and do the things that we wanted to do. So the GLP-1 receptor agonists, they are designed to mimic the impact of GLP-1, but we've made some kind of fun, neat little changes to them. So on top, you see this is the amino acid sequence. These are the amino acids that make up native human GLP-1 hormone. Liraglutide, which is known as Victoza. You can see there are only very few changes in light blue here. This is called analog technology, where we change the amino acid sequence of a human molecule to make it act differently. And what this change here does is it makes this particular GLP-1 receptor agonist, liraglutide, resistant to breakdown by that enzyme DPP-4. So you can inject GLP-1 underneath the skin, it will get in the bloodstream, it will start mimicking what GLP-1 does, but it won't get broken down by the natural DPP-4 because very smart people, much smarter than I, have designed it to be resistant to that. All right. This is an older GLP-1 receptor called exenatide, which you can see had a lot less similarity to human GLP-1. So these are the GLP-1 receptor agonists that we currently have on the market. We have shorter acting ones that exenatide or Byetta and lexazinatide that you take either twice a day or once a day. And then we have our longer acting forms. There's liraglutide, which is Victoza, exenatide ER or Bidurian. Abiglutide weekly was taken off the market because it just wasn't successful. And dulaglutide weekly is Trulicity. And semaglutide weekly is Ozempic. So we now have forms where you can give these medications twice daily, or even once weekly. So when we talk about compliance and being able to take your medication, I think it's a lot easier sometimes to remember to take one shot a week than twice a day. These medications lower your A1C by about 1 to 1.5%. But what's nice is because of the effects on the brain we talked about by decreasing the appetite, and by slowing gastric emptying and making you feel full much sooner, the patients typically lose somewhere between 3 to 5 kilograms on average in the clinical trials. I've had patients lose much more weight than that on these medications. And if you look at the weight loss with Ozempic, which is semaglutide, the average weight loss with them was more like 6 to 8 kilograms, which translates into somewhere around 15 to 18 pounds. So if you can we now have diabetes medications that will help you lose weight as well, which is one of the components of type 2 diabetes. I had a pharmacology professor, I still remember, I remember a lot of what he told me, but one of the things he always told me was that medications are poisons. All right, so it's always a risk versus benefit calculation that you have to make. So these medications, although they do closely mimic human GLP-1, they are not the same as human GLP-1, and the most common side effect of these medications is nausea, and it's not trivial. In the clinical trials of these medications, about 15 to 40% of patients started on these medications can experience nausea. Almost all of these GLP-1 receptor agonists will have a titration phase, so you start at a lower dose and you slowly work your way up to the max dose. That has been shown to dramatically reduce the risk of nausea. And because this hormone was mimicked after a hormone that our body actually made, and our body always does things better than what we can design, GLP-1 causes the release of insulin from your pancreas in what we call a glucose-dependent manner, meaning it only will stimulate release of glucose when the blood sugars are elevated. So it has a built-in kind of defense mechanism against low blood sugars. So we're going to go through some of the clinical data here. This is the LEADER trial. Again, I'm going to skip a couple of these slides because I really want to make sure we get through everything tonight. This was just the details of the LEADER trial, but all these cardiovascular outcome trials use what we call a composite outcome. So they look at the risk of either dying from cardiovascular disease, having a non-fatal heart attack, or a non-fatal stroke. So those are the endpoints that they use in the clinical trials. When someone has one of those components, they're considered to have an event and they drop out of the trial. Okay. So I promised I have to show some science because this is super exciting, even though it may not look exciting. This is the LEADER trial. So in the blue line you have liraglutide, which is Victoza, and in the gray line you have the placebo. And what you see here, that starting around month number 12, you start to see a separation of these lines. Okay, this is called a Kaplan-Meier curve. So this is the percentage of patients that have an event. You can see as the trial goes on farther, more and more patients have events. These patients were high risk, so they either had established coronary artery disease or they had significant risk factors for heart disease. So this was not your typical patient population without risk factors. These were at-risk individuals. And what you can see here by what we call the hazard ratio, so when this is less than 1, it means that it decreased your risk. There was a 13% reduction in that composite outcome in patients who were treated with liraglutide for an average of 3.8 years compared with the placebo. The SUSTAIN 6 trial, which again was another cardiovascular outcome trial looking at semaglutide, which was its Ozempic. You can see here that you see the separation, and what really blew our minds here is you start to see the separation fairly early on, and these curves begin to separate and continue to separate at the end of the trial. And what you see here, based on your hazard ratio being less than 1, and me being able to correctly do the math, I think it showed a 26% reduction in that composite cardiovascular outcome. So not only did these trials do what they were set out to do and show that these medications were safe, they didn't increase the risk of cardiovascular disease, but they actually reduced significantly the risk of having one of those 3 composite endpoints. And up until this, up until 2016, we never had anything like this. Okay, this was something brand new for us. In addition, we got data on risks of hospitalizations for heart failure. We now have data from these long trials looking at progression of chronic kidney disease. So we have a tremendous amount of new information from these really long trials that had a lot more patients in them. So one other class of medications that's exciting to talk about is the SGLT2 inhibitors. This is probably the newest class of medication, and it blocks the reabsorption of glucose by your kidney. I bet you didn't know that one of the things your kidneys do, other than thinking about having to pee 47 minutes into this talk already, is that your kidneys actually reabsorb glucose, and they can reabsorb up to about 180 to 200 grams of glucose per day. All right, and they do so by using a certain particular channel, which we'll talk about. These medications have a low risk of hypoglycemia. Typically, patients have a 2 to 3 kilogram weight loss, at least in the clinical trials with these medications. But as you may have seen from if you stay up past 6:30 at night and watch television, you may have noticed that these medications, again, balancing the risks and benefits, have an increased risk of infection, both fungal infections of the tip of the penis and vaginal yeast infections, but also Fournier's gangrene, which is a serious infection of the genital region, and then dehydration from increased urine output. Because what this does is, I don't know if how you remember high school or college biology, but this is the glomeruli. So this is the the artery that comes into each one of these nephrons, and in your kidney you have millions of these nephrons. And what happens is the sugar comes in and then gets brought into the nephron and then reabsorbed by the SGLT2 channel. And what the SGLT2 inhibitors do is they block that channel, which allows glucose to then just pass through the kidney and go out in the urine. So what's interesting is that it doesn't matter what type of diabetes you have, right? It doesn't matter if you have insulin deficiency from type 1 diabetes or if you have insulin resistance, et cetera, from type 2 diabetes. This medication will work for both people with type 1 and type 2 diabetes. It's currently only FDA approved for use in patients with type 2 diabetes, although it has been studied in patients with type 1 diabetes quite successfully. The reality is that as of yet, no company has decided to do the $400 million trial to show that it's safe in type 1 to get FDA approval. So back in 2015, this was the first of those trials that came out positive. This is empagliflozin or Jardiance. You can again see the separation between the two trials with a 14% reduction in that 3-point cardiac endpoint. So now we have liraglutide, semaglutide, and empagliflozin as medications that reduce your risk of heart disease. And this was quite, not only did it reduce your risk of that composite endpoint by 14%, it reduced the risk of cardiovascular death by 38%. So in this trial, all the patients in this trial had known coronary artery disease. So if you have known coronary artery disease, if you've had a heart attack, this medication has been shown in clinical trials to reduce your risk of dying from a cardiovascular cause by almost 40%, which is truly remarkable for a diabetes medication and is right up there with ACE inhibitors and some other medications that we use regularly. The Canvas program, which is Invokana, or canagliflozin is the generic name, again showed an exact 14% reduction. So now we have liraglutide, semaglutide, empagliflozin, and canagliflozin that not only were shown to be safe, but showed to reduce your risk of cardiovascular endpoints. So all this information has really been put together, and I showed you that they were published in 2015 and 2016. But what we see here is that now, finally in 2017, and these consensus guidelines that were released in Berlin at the ADA EASD meeting, we now have an algorithm for the treatment of diabetes that starts with metformin and lifestyle modifications, and then the next step, for the first time ever in the history of taking care of diabetes in the world, we use a patient characteristic to derive our next step. So the next question we ask our patients is, do they have established coronary artery disease? And if they do so, is there heart failure or chronic kidney disease? Because we will use one of those two classes of medications that we just reviewed, the GLP-1 receptor agonist or the SGLT2 inhibitors. So I know this doesn't sound super exciting, but this is earth-shattering for the way we've taken care of diabetes. Before, every decision we made about treatment choice was based on the ability of a medication to lower someone's A1C. We know that there's a lot more to the story than that now. All right, now for the fun part. Does anyone know what this is? This is an insulin pump, believe it or not. This was the first prototype that came out in the 1960s. I have some of my patients that worry about whether or not someone can see their insulin pump underneath their shirt. I'm pretty sure someone could spot you coming down the hallway with this baby on. So this was the 1960s. We're going to talk at pumps at the end, but what we're going to start with first is continuous glucose monitors. And there's a couple really exciting ones that are on the market now that I wanted to spend some time talking about. This is the Dexcom G6 continuous glucose monitor. What you can see here is that this device labeled number 1 is the application device. You pull a safety from the bottom, you press this against your skin, and you press the orange button. It's a one-time applicator. You throw the applicator away. So that inserts a small cannula, a little flexible cannula, into your subcutaneous space, so it does not go into your bloodstream. It goes into the subcutaneous space. And then through some cool technology with the way glucose transmits certain types of electronic signals, it is then when you then attach number 2, which is your sensor, to that particular cannula, you now get blood sugar reports from your interstitial space sent to your iPhone, sent to your receiver, or sent to your iWatch every 5 minutes. So before, if I had a patient who checked their blood sugars a lot, it was 10 times a day, right? So now you can get it every 5 minutes. And the wonderful thing about this particular glucose monitor is you can set alarms. So you can set this monitor to say, I want to know when my blood sugar reaches 80. So I tell my patients to set it at 80 so that they catch themselves before they get to have low blood sugars. This is running 24 hours a day. So when you are asleep, you now feel comfortable that someone is checking your blood sugars every 5 minutes while you're asleep and will let you know if you are getting low or getting close to low. You can see these arrows that you see on your phone here. This person is at 110 and has perfectly steady blood sugars. If their blood sugars were rising, you could see one arrow going up or two arrows going up. If they were dropping fast, even if their blood sugar was normal at 110, but it went from 350 to 110 within 30 minutes, you would see a double down arrow. So it allows you to say, you know what, this is going to end up being a low blood sugar, but I now have the data to prevent that low blood sugar. For patients who have hypoglycemic unawareness, who are unaware that they have low blood sugars and don't have symptoms, this has truly been a lifesaver for patients. They're able to work again. They're able to drive again if I let them. So pretty tremendous. These sensors are worn for 10 days at a time. They are water resistant. And it's truly the most important thing is that how many calibrations do you think this machine needs per day to stay accurate? 0. So if you read between the lines, if you wear this device, you never have to check your blood sugars again. This device will give you blood sugars every 5 minutes with alarms. So this is Quincy. He's a koala at the San Diego Zoo. In June of 2018, he has diabetes, and he now wears a Dexcom G6 sensor. And his zookeepers can sit in the safety, although I'm not sure. I think koalas, they actually look really cute, but I heard they're supposed to be really mean. So you can actually sit in the safety of wherever koala keepers sit during the day, and you can monitor Quincy's blood sugars remotely and make sure he's doing okay. There are share programs with the Dexcom G6 continuous glucose monitor, so if you have a child with diabetes, you can watch their blood sugar all the time. I was sitting at a soccer game last year on the sidelines, sitting next to a parent who picked up the phone and called their teenage daughter at home and said, "Did you know you're 45? And they said, "Yes, Mom, I know I'm 45. I've already treated it." I could hear the sass coming through the other side of the phone, so I definitely knew it was their teenager, as I do have one myself now. So these really are revolutionary, and these are available for patients with type 2 and type 1 diabetes, and they're actually available for Medicare and Medicaid as of very recently. Now, I'm going to bring you down a set of logic that really blows my mind. If you have Medicare or Medicaid, in order to get this device, the government requires you to to turn in that you've checked your blood sugars at least 4 times a day for the last month to get a device that allows you to no longer check your blood sugars. That's what we're working against, folks, right? So I just think that blows my mind. So you have to demonstrate that you're checking your blood sugars to get a device so you don't have to check your blood sugars anymore. All right, this is the Freestyle Libre. Has anyone seen this or know someone who has this device? So this is a really neat device. These are the pods that are seen here. This is, again, a continuous glucose monitor. Gives information, checks your blood sugar in the interstitial space every 5 minutes. And what's neat is that patients can carry around this receiver, and all you have to do is wipe the receiver over top of that particular sensor, and it will tell you what your blood sugar is. Okay? Again, no need to check your blood sugars, no need to calibrate this machine. All right? What this machine doesn't have is it doesn't have alarms. Okay, so you can't set a low alarm. It won't tell you when you have to physically put it over top to find out what your blood sugars are. But when you look at it, when you put it over top, it will give you an 8-hour display. So you know what your blood sugars have been doing over the last 8 hours. It's not just a one single number. So kind of super unique. Very discreet. These are very thin. They can hide under clothing. You don't have to roll up your sleeve. You can literally just take it in a meeting and brush it up against your arm and get your readings like that. Again, these are also covered by Medicare and Medicaid, and you still have to show them you check your blood sugars in order to not check your blood sugars. So this one I'm really excited about. This has been available in Europe for quite some time now. You may have read about it on some of the diabetes blogs. But this is the Eversense. So I'm not excited about this because I went into endocrinology because I hate doing procedures. I didn't even like doing throat swabs when I was in family medicine rotation. So what you can see on your left-hand side is the actual sensor. And that sensor gets implanted underneath your skin. So you would come to my office and there's a fancy little device that I would use. I would numb up your skin. I'm not doing this, but somebody in my office will do it. They'll numb up your skin. Maybe I'll do it. I'll do it for some of you. No, I'll do it for anybody. And you numb up the skin and you insert this sensor underneath the skin. And then over top of it is your receiver, which you see here in the middle. And that receiver will then send blood sugars every 5 minutes to an app on your phone, all right? And what's neat is that this receiver can pop off. So you can pop off the receiver and recharge it if you want to get its batteries. And you won't disturb the sensor because the sensor's underneath your skin. How long do you think that thing can stay underneath there? 90 days. So you now have a sensor that, and this actually in head-to-head trials has been shown to give you the most accurate readings of any of the continuous glucose monitors. So you now can have something that continuously transmit your blood sugars every 5 minutes for 90 days without one blood sugar check, without any calibration. So really moving in a direction that's pretty amazing as far as technology is concerned. Here are the just some newer pump technologies. We're going to talk a little bit about the 670G over here. There are now basically 3 companies that make insulin pumps in the United States. There's the Omnipod, which is seen here. This is a wireless insulin pump. So this cartridge has the insulin on it, and you put that cartridge on your body. So there are no tubing or anything attached to anything else. It comes with this smart device that is not only controls your pump, but also acts as your glucometer. So you can check your blood sugars there. This is a T-Slim pump. This has a connection, and you'll see what we're talking about with a tubeless system and a tube system. The wonderful thing about the T-Slim is it has great menus. It's similar to a smartphone, so a lot of the younger folks really like it because it's very intuitive with regards to the menus and very easy to change. All of these sensors are in the process of working with either Dexcom or another sensor company in order to connect their sensor to their pump so that you could wear a Dexcom G6 sensor, and that Dexcom would send information directly to your pump so that you wouldn't have to check your blood sugars or input numbers anymore. So that's on the way. So this is the Medtronic 670G. This is our first closed loop insulin pump. And by closed loop, what I mean is that you can see that, and this is, I probably don't have to tell you this, but this is not a picture of my abdomen. I am not modeling this, just in case you're wondering. This is the Guardian 3 sensor here. So this sensor is attached on one part of the body. Here's the Medtronic pump with the tube that's connected to the catheter, and inside this catheter, underneath this bandage is the catheter system that is stuck into the interstitial space. So this sensor is communicating numbers to this pump every 5 minutes. And why it's closed loop is the pump now is actually using that information on a minute-to-minute basis and makes changes in insulin delivery without any input from the person who's wearing this pump. Okay? So all day long, if you didn't eat, you could wear this pump and wear your sensor, and theoretically it will keep your blood sugars at 120 all day long. You still have to count your carbs and input how many carbs you're eating to give yourself a bolus, so it doesn't do that yet. But it runs your basal insulin, which means at nighttime, if you're sleeping and you start to drop low, your pump will turn off the insulin. It will suspend insulin delivery, and you won't even have to know. There are a lot of safety mechanisms based in here. A lot of people who wear this pump, it's not as beautiful as I make it to sound. There are a lot of alarms. There's a lot of systems the FDA required basically to overemphasize safety. So the newer generations of these closed loop pumps will have less alarms, but it requires people to stay in automatic mode. So this is the printout that I get of someone on a 670G. The blue is A, which is this column here. You can see 0% time spent in hypoglycemia. No hypoglycemia in this patient. 76% of time this person was in the exact range we want them to be, and they spent about 24% mildly elevated. And you can see that in A over here, they spent 92% or 6 days and 11 hours out of 7 days in automatic mode, meaning the pump was basically working for them most of the time they were wearing this. And what I want you to see is that look at this line and look at the variation. So the blue is variation from that median. Look how tight that line is. Sleeping overnight, this person's blood sugar stayed at 120 literally for 8 hours straight with almost no fluctuation, okay? And which is great is that I don't even really need to think anymore. These printouts say, hey, look, Dr. Gilbert, we see that in number 1, there's some hyperglycemia. This is probably after their breakfast, right? So they eat breakfast and we see a spike. So we'll fix that by changing his carb ratio. Maybe instead of 1 to 4, we'll drop it to 1 to 3. or perhaps we'll stress this person, it was a he, that's why I'm saying he, to check their particular, or count their carbs more accurately. Now, in contrast, you see B, which is this column here, still only 1% hypoglycemia, 51% in range, much more hyperglycemia, only spent 39% in automatic mode, 2 days and 18 hours out of 7 days. And look at this tracing. A lot more variability. So you can see that staying in automatic mode and keeping in automatic mode is very important. And most of the time that I spend at visits now with these folks is not adjusting basal rates, not adjusting carb ratios, is looking over them and trying to find ways to make sure they stay in automatic mode. It gives me hints and cheats every time they're kicked out of automatic mode. It gives a reason why. So I can sit there with them and say, hey, you know what, you're getting kicked out of automatic mode because your sensor is asking to be calibrated and you're not calibrating it. So it's behaviors that we can work on. This sensor needs to be calibrated multiple times per day. So unlike those other sensors we talked about that don't have a pump attached to it, because it's running an insulin algorithm, it needs to be done on a regular basis. So what's next? The artificial pancreas. This has been vigorously tested. Papers come out now once a year. The most recent one included vigorous exercise at high altitude and extreme temperatures. So guess what these folks got to do for this clinical trial? What would combine those three things? Skiing. So these patients got to ski for their clinical trial and in Colorado at really high altitude. So what the artificial pancreas is going to do is it's going to have a similar system where there's a sensor and a insulin pump. The sensor is going to communicate to the pump, but it's going to do everything. It's going to do mealtime boluses. It's going to maintain basal rates. And it's also, in addition to insulin, it's also going to have glucagon, which is one of the other hormones that's missing in patients with type 1. So if your blood sugars start to drop, instead of just turning off insulin, it's actually going to give you small microscopic amounts of glucagon, just like your pancreas would do. So you'll basically be wearing a pancreas on your belt. And this is not George Jetson. This is like 2 to 3 years from now at the most, probably sooner than that. All right? And the training for this particular pump in the clinical trials, they brought the participant in, they hooked them up, they entered their weight into their pump, and they pressed go. That was the training required for the current artificial pancreas in development. So really some exciting stuff. So what can you do finally in the last 5 minutes here, and then I'm going to stay after to answer all your questions. What can you do to help diabetes or help your family member with diabetes? Some of this stuff is really simple, but sometimes it's doing the simple stuff and doing the simple stuff well that makes the most difference. See your doctor regularly. If your A1C or your blood pressure, your cholesterol isn't where it needs to be, probably you need to see your primary care doctor and or endocrinologist every 3 months. See your dentist regularly. A lot of dental plans now, if you have diabetes, will allow you to go for more frequent cleanings than patients without diabetes. You can sometimes go every 3 months, as much as I love that. I actually wanted to be a dentist in college for a long time until I hung out with, this is how exciting my spring break was in junior year. I spent the week hanging out with a dentist. I hope he doesn't watch closed circuit Vermont TV, but I didn't like it at all, so I didn't become a dentist. In addition to seeing your dentist, though, you need to see your eye provider, and it needs to be a dilated eye exam, right? You can go in, you can get your contacts adjusted, you can get your glasses adjusted, you get your bifocals, but they need to do a dilated eye exam. This does not have to be done by an ophthalmologist, so a physician. This can be done by an optometrist. Okay, they all know how to recognize and identify diabetic eye disease, and if they find it on your screening exam, they'll then refer you to an expert in the field. Exercise on a regular basis and lose weight if you need to. I tell my patients, you don't have to join a marathon or a dragon boat team. You don't have to go on the kelp diet or the keto diet or the keto kelp diet or whatever combination we're at right now. What you need to do is lose 5 to 7% of your weight. We know that 5 to 7% weight loss will impact your blood sugars. Obviously, more is better. In patients with bariatric surgery, who lose obviously much bigger percentages than that, 85% of patients who receive bariatric surgery and lose tremendous amounts of weight come off all of their medications for diabetes. So work on your diet, and sometimes working on your diet is difficult. Trust me, if you can take a look up here, it's something I struggle with on a regular basis as well. But see your diabetes educator, see your local nutritionist. Maybe there's someone who works through your primary care doctor's office or in the community that you've come in contact. Get the advice of a professional to how to manage all the craze with regards to diets. You want to obtain a urine test to look for early signs of kidney damage. It's a microalbumin. You need to do that yearly. I put that right there because I can tell you in the patients who I see in my clinic, this is most often the test that they are missing from their primary care provider. So make sure that you ask and make sure that you have that updated in your chart. Check your blood pressure on a regular basis. The current recommendations from the American Diabetes Association is to have all patients with diabetes and high blood pressure should have a home blood pressure cuff to check your blood pressure intermittently at home as well as in the office, because some people come into the office and they're really, really excited to see me and their blood pressure is a little bit higher than typically at home. So this is a way of getting around me putting you on more medicine. You want to get your cholesterol level checked. Currently in the United States, if you're over the age of 40 and you have diabetes, there are very few reasons why you should not be on a statin medication to lower your cholesterol. So that's a conversation you want to have with your primary care doctor as well. Most important thing, take your medication. What do you think on average is, so I listened to a person at Johns Hopkins University whose expertise, he's a psychologist, his expertise is in medical adherence to prescribed medications. What do you think, and we've seen this in real world trials as well, what do you think the percentage of patients that take their medication as prescribed is in the United States? 30%. So there's a glass half empty up on that side. It's about 50%. So 50% of patients take their medication as prescribed. And there's a lot of factors that go into that. But one of the most important things you can do for your diabetes is take your medication and take it regularly. Stay informed regarding new treatments and ask your provider when you see them next. Ask them about some of these medications we talked about. Are these a better fit for me than from what I'm on? Not only for cardiac protection, but rates of hypoglycemia and weight loss. Am I on the correct cocktail of medications that give me the most benefit and the least amount of risk? Stop smoking. So in conclusion, diabetes is a worldwide epidemic. There's significant financial and a significant human cost as well, as we saw in the beginning. The new treatments are changing every day, and they're literally changing the lives of people with diabetes on a regular basis. Every day there is literally something new that is exciting in the world of diabetes. Stay up to date, ask your provider, and most importantly, take care of yourselves. So thank you very much for the opportunity to share this evening with you. I know I went a little over time, so I apologize for those of you who have a dinner date. What I'm going to do is turn off this mic, and I'm going to turn on the lapel mic so I can come into what they call, in public speaking, the intimate zone to answer your questions.
Hello, I have a question. How can we learn from European countries because they have a very low incidence of diabetes, even as like Eastern European poor countries, which are from the very lowest.
Right, so I think, the question is, what can we learn from the Europeans? So one of the things that we can learn from the Europeans is ride a bike, right? So just in general exercise. Europeans exercise far more than the United States. Better public transport, better accessibility to sidewalks. These are all been shown in clinical trials that they have better infrastructure with regard to exercise. Europeans smoke a little bit more than the United States, so that's something that, despite having some increased risk of smoking, still have a lower risk of heart disease, et cetera. I think you see the benefits of socialized medicine in some of these countries where everyone, regardless of whether or not you're employed or not employed, has access to primary care and medications. The reality is that we call it type 2 diabetes, but it's really different around the world. The average BMI of someone in Japan with type 2 diabetes is 25, okay? If you gave everyone in the United States a BMI of 25, we would get rid of 80% of diabetes instantaneously. If you look at sub-Saharan Africa, they're doing all the things that we think you're supposed to do, right? They eat locally, they exercise, they don't eat processed foods, yet their rates of type 2 diabetes are exploding. So there's a lot we don't understand about this particular condition. But I think if there's one lesson that we can learn from the Europeans is good access to health care and exercising regularly. And probably some red wine.
My question has to do with the SGLT2 inhibitor. Is there any way that a type 1 diabetic can, because their sugar is elevated, why isn't that being used to help them pee off some of
Sure.
that extra sugar and
Sure.
lower their blood glucose?
You're absolutely right. The mechanism of action of those medications will work in someone with type 1 diabetes. And there's been small open label trials published in Diabetes Care that show patients with type 1, when given an SGLT2 inhibitor, have less hypoglycemia, use less insulin, and have less variability in their mealtime insulins. The problem is that these medications are expensive. And if they don't have an FDA approval to be used in patients with type 1 diabetes, I can prescribe it for you, but your insurance company is not going to pay for it.
How expensive is it?
Very expensive. Hundreds of dollars a month, for sure.
Thank you.
The good news is that there's some trials underway of a combination of SGLT1, which is another glucose one that is found in the gut, and SGLT2, a combined medication that is actually being studied in patients with type 1 diabetes. So we will have, when that comes out, then the insurance companies, then I got them. Then they can't deny it from me anymore. So it's only a matter of time till that study's completed and that data's out. But I do have patients who pay out of pocket for SGLT2 inhibitors who have type 1 diabetes.
You showed a chart where there were significant increases in the Middle East, North Africa, and Southeast Asia. Why?
Yeah, so great question. There's been a lot of theories put forth on that. Some of that is westernization of diet. So as these countries, particularly Dubai, has one of the highest rates of prevalence of diabetes in the Middle East because they are affluent and they exercise less and they have a more westernized diet as well. So we see the explosion in India as well, similar issues. In India, there's no such thing as health insurance. So patients go in and see their doctors, and I was just at a global panel speaking with some doctors from India, and patients pay out of pocket for their information or for their medications, and they buy them from their doctor's office. So patients often will go out and raise money and come and buy 2 tablets and come back the next day and buy 2 more tablets. So access to medication and cost of medication is a big barrier in a lot of these other parts of the world. And in fact, you see patterns of medication use. So there's a class of medications called the alpha-glucosidase inhibitors, which block the breakdown of sugars in your gut. So you pass more of the sugar so you don't absorb the blood through the gut. Significant levels of flatulence, about 20 to 25% have significant flatulence and diarrhea. Used a little bit more in Europe. Apparently they're a little bit more comfortable with flatulence than we are here in the United States. But in India, if I went to India and gave this presentation, half the people would walk out because it's not practical to them, because they don't have access to these medications. They can't afford these medications. And they use SGLT2 inhibitors, which are cheaper. So it's a combination of a lot of diet factors. There's environmental factors that clearly are playing a role in that we don't have a good handle on. But there's also socioeconomic and political factors as well, which is why epidemics happen, right? Pandemics happen, because there's usually more than one thing. There's more than just the biology, or there's the biology in the political context and the socioeconomic context that causes things to really become problematic. Great question.
I'm wondering about the access to information. I mean, one of the things that I noticed when I'm hearing this presentation is a few years ago, my father had a diabetes diagnosis, and there were various low classes and other kinds of things, and attempts to provide information by doctors and stuff. And I think they were conscientious about it, but a lot of this kind of information we really didn't get.
Yep.
And when I do like web searches on things, I mean, I'm proficient enough, I can look at primary source literature.
Yep.
But a lot of times there's such a huge gap between
Sure.
between what's sort of presented to consumers and sort of really kind of detailed information. And it seems to me like, as a person with other chronic conditions, like that if you're going to live with something the rest of your life, have access to good, well put together, up-to-date information would be really helpful. Yeah.
No, you're absolutely right, and it's something that the internet has its pluses and minuses, right? Websites like the American Diabetes Association European Association for Study Diabetes. They have kind of professional side websites and more public-oriented websites as well. So those are always great informations. Your local certified diabetes educator, you have to look for local programs in your area that I know our CDEs run classes. So in addition to seeing them individually, you can go to a class with a diabetes educator. How many endocrinologists do you think are in the state of Vermont? Yeah, not enough maybe. So there's 10, and 7 of them are right here at UVM. So endocrinologists aren't going to solve this problem, right? And the problem is that your primary care provider, right, has to know everything about, has to know all this stuff that just exploded on diabetes, and heart failure, and hypertension, and cholesterol, and how to adjust your warfarin, and your asthma, and your COPD, and all these other things, because diabetes is not, I mean, that's the area that I'm in, so this is the area that I follow. There are equal advances in all these. I mean, I flipped to the New England Journal, and I did my internal medicine training. I graduated in 2007. I don't even recognize half the medications that are advertised in the New England Journal of Medicine, right? So, I think having good sources is important, and seeking out good sources. WebMD, Cleveland Clinic, they oftentimes will have some really great, the Mayo Clinic has a great website as well for basic information. The ADA, you can sign up for alerts, so you can give them your email so they'll alert you when there's something new that comes out, particular technology. The fact that the Eversense was approved in the United States on November 1st, I found out sitting at a conference on Friday afternoon. So here I am, feel like I'm connected, right? Have my pulse on the new diabetes technologies, and it took me 12 days to figure out. I didn't get any alerts, nothing happened in my email. I just found out from someone else telling me. So.
For a person with type 1 diabetes, realistically, when do you think that artificial pancreas will be widely available?
I would say widely available within 3 years, easily.
And will it be similar to the closed system?
Mm-hmm. Yeah, so they'll look very similar. The sensors will probably be a little bit more advanced and a little bit better. The sensors will probably be smaller. The cannulas may be more flexible, so we're constantly making improvements. If you've talked to anyone who's used continuous glucose monitors since the beginning, they used to be these kind of harpoon-like metal, and now we have these beautiful flexible cannulas that I had to wear one from a conference and forgot someone said, well, where are you wearing it? And I couldn't remember which side I had put it on because I really didn't feel it. So it's coming for sure. But even before that, between the closed loop or even just, we talk about the new technologies. I have patients who are using multiple daily injections who are on a Dexcom sensor who have A1Cs of 6.4% are doing great. So you don't need, someone told me the other day that the insulin pump is just the world's fanciest insulin pen. If you think about it, it's still delivering insulin subcutaneously, just like an insulin pen does. It just has a lot of other algorithms and gadgets and stuff to do it. The idea behind the technology is try to take some of the burden away from patients with type 1 diabetes, checking the blood sugars, worrying about, if you think about having type 1 diabetes, if you don't have type 1 diabetes, you have to think about your blood sugar before you drive, after you drive, while you're driving, when you go to bed, when you wake up, in the middle of the night, before you eat, after you eat, when you go out to eat, when you go to a birthday party, when you're at college and you have your first, 6 natural lights or whatever that you have. So there's just tremendous amount. So these technologies are designed to really take the burden off of folks. And that's my hope, that these technologies will make the quality of the life of people with type 1 diabetes much better, because they're spending less time dealing with their diabetes, but yet still having equal, if not better, control.
So just a reminder not to ask a question unless you have the mic in your hand, so everybody can hear the question that you're asking, and we'll be handing them out.
How do you define pre-diabetes? You referred to that earlier.
Yeah, so that's a great question. So there's a clinical definition of pre-diabetes. So there are 3 ways that you can be screened for diabetes. That is an oral glucose tolerance test, which hardly anyone does anymore. You can get a fasting morning blood sugar, and you can get an A1C. So the A1C and the fasting morning blood sugar are the 2 most common. So an A1C value so normal is considered to be less than 5.7%. So anything between 5.7% and 6.4% is considered prediabetes or impaired glucose tolerance. It's a technical term for it. Anything above 6.5 or above is the diagnosis of diabetes. Fasting blood sugar, normal patients without diabetes will have a fasting blood sugar less than 100. So if your blood sugar is between 100 and 126, that's considered prediabetes. Greater than 126 on 2 separate occasions is considered diagnosis of diabetes. So they're diagnostic tools, and you can trend. I have patients who actually come to see me for prediabetes, and we've seen their A1C go from 6.1 to 5.7 to 5.4. With weight. And so there was a giant diabetes prevention trial, huge randomized control trial that looked at using medications versus diet and exercise for trying to prevent patients from going from prediabetes to diabetes. We can prevent 60% of the folks who have prediabetes from ever getting type 2 diabetes by doing the things in the DPPT that were shown to be successful, and that was 5 to 7% weight loss and significant changes in their diet. So an increase in physical activity. Now the physical activity in these clinical trials was not, I take my dog that's this big, I walk them around the yard in the wintertime and scoop their poop and go home, right? This was vigorous exercise. So that's where meeting with someone like a diabetes educator who's familiar with those recommendations can sit down with you and say, hey, we know that from this clinical trial, we can reduce your risk of developing diabetes quite significantly, but these are the things, these are the targets. We need to lose this amount of weight. You need to exercise 150 minutes of moderate intensity exercise per week. You need to get 2 sessions in per week of strength training and resistance training. So there's specific criteria that you need to use. So.
I have 2 questions about the glucose level implants.
Yep.
The first one is, do they ever get infected? And the second is, how do you remove them?
Yeah, great question. So I've never done the implants. Anytime you break the skin, there's always a risk for an infection, whether it's through an insulin syringe or through these catheters. And patients who wear catheters for glucose sensors or for insulin pumps will occasionally get infected sites. We wash the area with an alcohol pad, which should destroy most of the skin bacteria before you implant it. For the implant, or before you put on a sensor catheter. For the implanted device, that area will be scrubbed and cleaned with alcohol and probably this chlorhexidine spray, which has been shown to reduce infection from skin bacteria. And then it will be done with sterile gloves, et cetera. So they'll try to reduce the risk. But there always is a possibility, correct? But the risk is very low if you take care of yourself and take care of the site. Good question. Yes.
You and many other endocrinologists get together at different conferences to discuss these things. Mm-hmm. Well, I listened to all the drugs that you mentioned, all these new, very progressive drugs, and the prices are absolutely outrageous. And why don't the group of you, all endocrinologists in the States, they must feel the same way, lobby to get these prices reduced? And it can be done, because I myself can give you an example where I needed Crestor, and I went to Canada, and I was paying a third of the price. I was paying like $70 for 3 months, and here it was like $140 per month. And it is available, and where is the will of all the physicians that are trying to help people to put the pressure on these pharmaceutical companies to reduce their prices, to make them accessible, that people can get better?
Yeah, I think it's an excellent point, and it's an area where probably physicians have failed to be leaders in that advocacy. There are, I can name, there's a number of highly visible endocrinologists around the country that speak about this topic at national meetings and have lobbied Congress and have met with congressmen, et cetera. But the reality...
But if you told your patients that you were going to do something and they sign petitions and everybody does that, it will turn into hundreds of thousands, if not more, of signatures to start putting some real pressure on politicians that can then put pressure on the pharmaceutical companies.
Yeah, I'm unaware. I'd have to check of our professional organizations if there's any grassroots effort in that, but it's certainly something that's worthwhile. Yeah.
So we're
Great
going to
point.
have just one last question up here. Dr. Gilbert has graciously said that he'll stay afterwards to answer any additional questions you have up front.
I just want to say one thing to your point. If you noticed when Senator Sanders spoke out about the price of insulin, the Lilly stock dropped 26% in one day. So we can have an impact on this if we speak out. So you're absolutely right.
Look at the EpiPen, for
Yeah,
example.
exactly. As the outcry, public outcry. Yeah. Yeah. Right. Right. And the reality is that the drug companies recoup their price for these large clinical trials on the backs of Americans. Yes. Yep, you're absolutely correct.
Hi, my question is about the GLP-1 receptor agonist. When your diabetes reaches that level that you need that, when you start taking that, what is the likelihood that you'll be able to get off of that with diet and exercise and just really managing?
It's a great question. I mean, I think if I had my way, if I didn't have insurance companies and people could afford, things, I would put patients on metformin first, and then the second drug that I would use would be a GLP-1 receptor agonist. So I think the use of these medications, you're already seeing them kind of come out from this long list of medications that could be used to now move to the forefront because of some of the data that I showed you today. I think all patients with the right amount of weight loss can come off their diabetes medications. The issue always is, and I've had some patients who get newly diagnosed, put them on metformin, they come back in, their A1C 6%, they lost 25 pounds, they've gone to the gym and they look great, and they tell me, listen doc, I want to come off this medication. And what I'll tell them is that if that's what they need as far as an emotional kind of, I kicked metformin to the curb and to keep them motivated, I'll support that. But what the reality is that what you're seeing in the blood sugar and the A1C is one thing. What we can't tell is how hard the body, and particularly the pancreas, is working to maintain those blood sugars. So while you may take someone off their GLP-1 receptor agonist or their metformin, and their A1C may not change, their pancreas may be working 110% to overcome the insulin resistance because they're not getting the assistance of the medications. And what we believe is that may cause their beta cells to fail at a more quicker rate, and therefore requiring either more medications or perhaps earlier insulin than, say, someone who is maintained on their medication. So you oftentimes will see providers add medications rather than taking them away. But I have had some patients who say, I need this victory, I need this to keep motivated, and I tell them that story, and then they get to ultimately decide what they want to do. But good question.
Thank you so much for joining us tonight, everybody.
Thank you, everyone. Thank you. Thanks for coming.